You are listening to the Addiction Files, where we discuss evidence-based treatment, clinical pearls, and resources while striving to destigmatize the treatment of addiction in our medical culture and save lives. We are the Addiction Doctors, Dr. Darlene Petersen and Paula Cook. Welcome to the Addiction Files. We are back with Dr. Mason Turner, and we are discussing ADHD in the field of substance use disorders. And this is just an area that both Dr. Cook and I truly struggle with. First, how do we diagnose it in our patients, and then the management? And so obviously, Dr. Turner is well known to our podcast and just an expert in mental health disorders with substance use disorders. So I'm going to turn it over to Dr. Turner again to introduce himself, and then we'll get started.
Great. Thank you so much, Dr. Petersen. And I'm Mason Turner. I'm a psychiatrist and addiction medicine physician, and based out of Salt Lake City. And I actually work for Intermountain Health as the senior medical director for the Enterprise Behavioral Health Clinical Program.
Thanks for joining us, Mason. We were just saying how helpful your episodes have been. So for our listeners who are listening for the first time to you as a guest, really encourage them to tune in and listen to our series, if you will, on kind of common psychiatric conditions with substance use disorder. You've done an episode with us on depression and anxiety and psychosis, and and personality disorder, and they've all been incredibly helpful. They're just good. And in fact, there's some of our most downloaded episodes showing and demonstrating that the need to understand these conditions more is really needed. So thank you for joining us. And I agree with Darlene. We every day come across this common problem. Patients self-identify as having attention deficit or trouble with focus and concentration. And there's this dilemma of how do you treat people appropriately, especially in the context of using controlled substances that may of themselves be addicting. So I would love to talk to you about this and talk about best practices and also what your clinical experience is in the field.
Great. Yes. And I think the first place I'd like to start is really around the prevalence and how common ADHD is across the board, both in children, young adults, and even older adults as well. ADHD is actually the second most common diagnosis that we make in psychiatry, behind anxiety disorders and very close to depression. But in many respects, ADHD is much more functionally impairing than either of those conditions, simply because of the nature of it and the chronic nature, as well as the different impairments that go along with ADHD. So it's really important to know that as you're seeing patients, we know that at least 10% of the population at any given time has ADHD. And if you begin to look in treatment-seeking populations, those numbers go up dramatically. So if you're working in any kind of clinical environment, or you're treating addictions, or working at a psychiatric clinic, it's important to know that ADHD is really rampant, almost endemic in the population you're treating, and oftentimes goes undiagnosed or underdiagnosed, or we don't appreciate the severity of ADHD. Now, if we think about the incidence of ADHD and the prevalence of ADHD combined with substance use disorders, we know the two also go hand in hand. And you can actually parse various pieces of data. Sometimes it's 3 times greater incidence of ADHD and substance use disorders. Sometimes it's more like a 5 or 7. But we know that there's an order of magnitude greater risk of having a substance use disorder when you have ADHD, although we're not sure the reverse is true. So we know that most ADHD presents itself in childhood and adolescence, early adolescence. And then substance use disorders begin to really appear kind of later in life as well. So we want to look at the ADHD as really predating that substance use disorder, but oftentimes the diagnosis will occur afterwards.
When it comes to substance use disorders, is it classically just particularly stimulant use disorders where we would expect to see that 3 to 5-fold increase in diagnosis of ADHD, or should we be looking for it in all substance use disorders?
It's a really fascinating question, because if we think about the self-medication hypothesis, one would anticipate that actually stimulants would be more commonly abused in those with ADHD. It turns out in my clinical experience, I can't cite data to this effect, but I can say from my clinical experience, actually, I think the reverse is true. And part of that is because the effects of stimulants, methamphetamine, amphetamines, even cocaine, are such that people with ADHD actually get a treatment effect from those substances, and they don't abuse them the same way people who don't have ADHD abuse them. So really, it's across the board. But I would say use a lot of caution in how you interpret how someone responds to methamphetamine or cocaine or amphetamines if you suspect ADHD.
So could you say, I mean, obviously you have to be very careful with this, but can you use the response to illicit stimulants as diagnostic in a way that people say, well, they calm me down, I'm able to get more done. I mean, obviously everyone's more goal oriented, but in terms of like a more calming effect as being somewhat diagnostic.
It's a very interesting question. And if you ask 10 psychiatrists this question, you probably would get 20 different responses, depending on the day of the week and the time and the clinical experience we've had. But it really is important to recognize that ADHD diagnosis is a clinical diagnosis and is not based on empiric response to stimulant medications. The reason I say that is because we do sometimes notice these paradoxical effects. And I've had plenty of patients over time that have actually had very severe ADHD, used methamphetamine in a way to actually medicate their symptoms, and actually performed quite well, even when they were using methamphetamine or other stimulant medications and substances. However, that in and of itself does not diagnose ADHD because we know the response to substances does vary across populations, even without another mental health condition in the background. And so we do want to think about how do we go about diagnosing ADHD. My advice for your listeners around this particular question is that it is very difficult to actually diagnose ADHD either in active use or in early recovery for any substance at all. And largely that's because ADHD is actually a diagnosis of exclusion to a degree. So we're looking for the absence of other conditions or other diagnoses. And it's very difficult to actually exclude those diagnoses in early recovery, really up to the first 3, 6, 12 months of recovery, even. However, we also know that if we dig deep enough into the history, if we interview family members, if we have access to school records, or in great situations, have really great documentation from parents about how people did in school and how they actually performed, and comments from teachers and friends, we can make the retrospective diagnosis looking at historical information. Again, a point of a bit of controversy, but I think most psychiatrists would agree that the symptoms of ADHD typically have onset before the age of 12. So if we really dig back to those younger years, we can make those diagnoses pretty reliably and then treat ADHD as we see fit. And in the various ways we can talk about how you treat ADHD, but it is important to make that diagnosis first and to be reasonably certain that you have the correct diagnosis.
That's so important. And this might be jumping ahead, but do you ever see a cause and effect from long-term stimulant use resulting in ADHD just because the brain cannot then focus and concentrate in a sustained manner? Obviously, when people initially stop using stimulants, their early recovery, like you said, they're going to have all kinds of withdrawal symptoms and rebound, but a protracted recovery from stimulants, does it ever cause ADHD? And do we have any clinical evidence of that?
That's actually a fantastic question. And I think one that a lot of people don't think about because it's not a recognized diagnosis in our DSM 5, right? So there's no diagnosis of acquired ADHD. But I think clinically, if we talk amongst ourselves as colleagues, as psychiatrists, as addiction medicine physicians, we do recognize this is a syndrome that we see in a couple of different instances. One of the more common ones is actually around traumatic brain injury, or even you may see minimal cognitive impairment that results from that, but you can see an acquired ADHD that is very difficult to treat and very functionally limiting, even if the neurological symptoms resolve from the TBI. But we also see this with long-term use of various substances. And I can't explain to you what the pathophysiology is. I can't tell you how you go about making those diagnoses, except to say it looks exactly like childhood onset ADHD, and it does respond to stimulant medications where that's appropriate.
Thank you. I agree because I think we see this all the time, and it's worrisome to make a decision about treatment. Although the ASAM stimulant treatment guidelines have been very helpful for that.
Yes.
So for diagnosis, you're saying, if we can dig back into the history for an antecedent record and history of ADHD, that makes it easier. It gets muddier when people have started using substances from a very early age, like preteen, or they can't recall the history. Or if people say, well, I started having trouble like in my early 20s and now I have all these symptoms. What's your approach to those folks? When you can't really make, this diagnosis of exclusion, you can't really definitively say that it started before age 12, but they exhibit some of the criteria from the DSM-5 otherwise.
So I think actually, when we look at the diagnosis of ADHD, a couple of pearls that I would just put out there as we begin to dig into this further. One, recognize that ADHD is a chronic illness. So we can look at the lifespan, and typically we will see some periods where ADHD has been more or less active depending on the demands of the individual. So perhaps we see a little bit less impairment as children when you have parents to serve as that executive functioning center. And then as kids move on to college or into young adulthood, the symptoms really become apparent when they don't have that parent around to modulate, to help them figure out how to get through the school day or get their homework done and so forth. And so I'll be very intentional to ask not only about symptoms, but what are some of the compensatory strategies that have been used? I might ask a parent, especially of a young adult, how hard did you have to work to get your kid to go to school, to do homework, to be able to complete tasks and things of that nature? And that will give me some insight about exactly what the level of impairment is. And I can map that back to symptoms that then give me more confidence in an ADHD diagnosis. I would also add another pearl is to keep in mind that unlike some of our other diagnoses in mental health and in psychiatry, ADHD does require a bit more faith, shall we say, that you're making the correct diagnosis and longitudinal observations over time. I can typically point to very clear mood episodes in a bipolar disorder or in a major depressive disorder. Typically, anxiety disorders, we can really sort out what's going on and point to clear symptoms, but I can't always do that with ADHD. So I might make a provisional diagnosis. I might actually get enough history that I feel comfortable recommending a treatment course. And then we kind of move forward and then constantly reassess the diagnosis. What's really important as you're working with a patient long term is to have some points along the way where you're asking yourself, does this diagnosis still make sense? Is what I know about this patient now 3 months, 6 months, 2 years, 5 years later still consistent with that diagnosis of ADHD? And do I need to look at other treatment options? Keep in mind that if we don't get that diagnosis correct, and there's another diagnosis like a depressive disorder or an anxiety disorder, the treatments are quite a bit different. And so we want to make sure to constantly ask ourselves, is this the only diagnosis? Is this the correct diagnosis? What information do I have to actually increase my confidence that this is the right diagnosis?
So, Mason, back to just with diagnosing, how much does like trauma confound like the ADHD diagnosis? So many of our patients come from really chaotic and like early childhood trauma background. And that seems sometimes difficult when we're meeting them. Is are we seeing some of this like difficulty with executive function a, a result of that? Or is this undiagnosed ADHD? Does that make sense?
It does. And it's another great question because I think in 10 years, 20 years from now, we'll recognize that trauma actually does real damage to the brain in ways that are far beyond post traumatic stress disorder. And so we think about the effects, particularly of early childhood trauma, is actually results in changes in our brain, our neurochemistry, our neural networks, and the way that our brain functions that actually do look a lot like ADHD, that cause problems with executive functioning, with attention, with completion of tasks, and so forth. And so, getting a really good and thorough trauma history, both at the initial meeting with the patient, but along the way as well, is really important to understanding all the complexities of what's happening with that patient. And I think trauma really is the great mimicker of a lot of different diagnoses. And many times when I'm in a situation where I don't know what to do with the patient, I've tried a course of medical treatments that are not working, perhaps some psychotherapeutic treatments as well. And I'm really wanting to look again at that diagnostic formulation. My mind always goes to trauma. Is there trauma that I'm missing? Can we go back and understand more about that person's childhood, their adolescence, their young adulthood through that lens, and then understand how these things all fit together? And I do think that we frequently, I do this, and I think my colleagues do this as well. We miss those effects in many different ways because we don't have a great way of screening out trauma at the very beginning. And then we forget to ask about it later on down the road.
That's such a great pearl. I think that's really important for us to remember because patients aren't always ready to immediately share that. And I mean, you just remind me of an encounter that I had with a patient yesterday that I had been seeing for a couple of months. And they come in, and when they're ready to share their trauma story with you, you're just floored by how could I have not seen this before? Right.
That's right. It happens all the time. And I think the other thing that happens as well is that we do underappreciate, I think, as a field, the impact of chaotic living environments. Many of our patients that are in addictions treatment come from families that suffered with addiction as well. And that kind of chaos as a child, that is a traumatic event and a traumatic experience that has long-term effects. And many times we ask about the assaults or we ask about emotional, physical, sexual abuse, but we forget that growing up in a chaotic environment that's quite neglectful is equally traumatic. And
Absolutely.
oftentimes we see those long-term effects.
That is very true. I'm interested in this idea about ADHD as a diagnosis of exclusion and how you tease out the difference between ADHD and maybe the most nearest relative in terms of what's on the differential. Would that be an anxiety disorder, or there's some other mood disorders that mimic it closely? When you're trying to determine what the diagnosis is, what do you most commonly try and differentiate between?
Yeah, and I will say that the idea of ADHD as a diagnosis of exclusion is not non-controversial. There are some people who believe very much that you can make a diagnosis of ADHD without excluding other diagnoses. But ADHD oftentimes does fly under the radar screen for many patients, and they become very used to the functional issues that it brings along with it. And they don't even report that as being a problem for them until you actually uncover that. So oftentimes patients are not leading out with attentional symptoms. Let's also keep in mind, particularly mood disorders, but even diagnoses ranging from personality disorders to anxiety disorders to really most any psychiatric diagnosis that we make can have attentional problems and often does have attentional problems, can come along with memory issues and difficulties with executive functioning, so that ability to plan and execute a function. The classic example I like to actually point out when someone's sitting in front of me, either virtually or in the office, to say, do you have any idea how many steps it took for you to get from calling to make this appointment until you showed up in this office? You had to know the number to call. You had to figure out how to make the appointment, what your schedule was that day. Where does your schedule live? Was it on your computer? Or did you keep it on paper? What is your insurance? What is your cost going to be? And so forth and so on. There are 100 steps to get from point A to point B. That's all executive functioning that gets us from point A to point B. And with ADHD, executive functioning is markedly impaired. That's usually the one impairment we see across the board. And unfortunately, it's one of the ones that does not respond to medication management, which we can talk about a bit later as well. So, as we approach that diagnosis, what I'm really looking at first are mood disorders. Frankly, that typically is the one that I do see the most and have the most level of confusion with the ADHD diagnosis. But let's also keep in mind that as individuals age, they will often lose the hyperactivity component, and it can really become more of an anxiety component. And so I do see patients with ADHD very, very anxious appearing. Treat their ADHD, the anxiety goes away. And that's because I think that those two symptoms of hyperactivity and anxiety are related a bit in adults in particular. So we do see some confusion with anxiety disorders as well. And then finally, the substance use disorder piece, I think we can't underestimate the role of that as well, because active substance use does look a lot like ADHD as well. And so, really teasing that out, what are the effects of substance versus an underlying mental health diagnosis? That's really important as well. Those are a couple of them, but really, any psychiatric diagnosis can mimic ADHD to a degree.
Okay,
What
thank you.
is useful that I would add, though, most psychiatric diagnoses do not have onset before the age of 12. So, again, if I can go back to seeing some symptoms, some evidence of some impairment earlier on, then that really does cinch that diagnosis of ADHD.
Well, that's very helpful. Let's talk about treatment. I mean, I think it'd be helpful to talk about treatment in general and then treatment for people with substance use disorder. I think because there, as we said, I mean, obviously that's the focus of our podcast, and it's this very special population that we're mindful of and that are more vulnerable.
So, treatment wise, I think we still recognize that psychostimulant medications are really the gold standard of treatment for ADHD. There are many other options that have been looked into and investigated, and some of which that can be helpful. Things like atomoxetine, even some of the antidepressants have shown some beneficial effects for ADHD, but none of them really are as quite as robust as the psychostimulant medications. And we have to recognize that it doesn't mean we're going to use those medications necessarily, but it is important to recognize that the effects of amphetamine salts, of methylphenidate, those types of medications are going to be much more significant for patients than the other medications that we might use. So, with that in mind, I like to think about treatment in general for ADHD for adolescents or children, and then for young adults and adults separately. And specifically to substance use disorders, we do know that treating ADHD very aggressively and really getting it under good control as early on as possible will predict a lot better outcomes into adulthood, a lot better learning potential, a lot better retention of material, but then also reduces the risk of substance use disorders as well. So, with kids and adolescents, it's really important to recognize, diagnose, and treat those conditions in whatever way you feel comfortable doing so. So, that's one of the first pearls that I would put out there in terms of the treatment pieces. There really is a difference between kids and adults. Now, when we look to adults, oftentimes what I'm really looking for is the degree of functional impairment from their ADHD. So, we've made a diagnosis, we've defined the symptoms, we understand how this presents in this individual. What I next want to understand is how is this affecting their daily life? What relationships have they lost because of their ADHD? What jobs have they lost? How difficult is it for them to actually do well in their work or their school and what have you? And that gives me a window into how likely am I to recommend treatment and what am I going to recommend? And so we have a conversation with the patient around how have you learned to manage these symptoms? And then how can medications play a role with that? And that's true whether you have a substance use disorder or not. But it's really important, I think, to make those distinctions. I would also say that we talk a lot about medication management for ADHD for a really good reason. Medications work and they work well for ADHD. I would even argue that if we look at the whole psychiatric pharmacopoeia, that these medications work the best for ADHD is for any psychiatric illness that we treat, including bipolar, depression, and so forth. So, really important role for medications in treatment of this particular condition. Having said that, the medications only treat a very narrow band of symptoms, typically inattention and hyperactivity, and then a few other related symptoms kind of around the edges of those. They do not teach you how to show up on time for an appointment. They do not help you to actually complete your work assignments and what have you. They actually treat the underlying symptoms. So, actually, helping patients to understand what are other resources, whether it's visual attention aids. Oftentimes, people with ADHD have terrible auditory attention, but really great visual attention. So, are there ways we actually can maximize that particular issue for them and help them to use visual attention more effectively? Are there ways we can help them to organize their lives in a way that helps to kind of account for those symptoms? And oftentimes, this is the role of a therapist. There are many online programs that do this, and even ADHD coaches as well.
So, do you have a standard resource you give people, like first line, for these kinds of behavioral tools? Do you refer them to a book or an app, or do you say go to a therapist who specializes with ADHD? What's your recommendation?
There are so many books that have been written about ADHD that are helpful that, frankly, I tell patients to go find something that's short enough for them to read, short enough for them to actually get through, something they're willing to actually work on. And they're oftentimes divided into kind of the basics of managing ADHD all the way up to more complicated ways of actually managing executive functioning. So no one particular book that I recommend, but something that actually works well for them. And that's would certainly be a homework assignment, as it were, that I would give them to actually look into some of those books or other online resources. Organizer wise, there are a lot of different apps and different organizers that actually have been developed and are very useful with ADHD. But usually, I'll recommend that people use some kind of visual or color coding aids that help them to organize their schedule that makes sense for them. So I think about my own Outlook calendar. That's what I use to manage my own calendar. And I have things that are color coded, right? Things that I can miss, things that have to be there for sure, or events like this podcast that are in bright red that I have to be on time for, and nothing else can interfere with my being here. So those are the kinds of techniques I'll work with people with ADHD around to say, think about color coding, think about how you organize the visual material, and then also think about how you need to receive material from other people. If they're in a job where they need to read a 50-page document to abstract information about something to do with their job, it is simply not going to work. They really need to work with their supervisors and other people to really maximize that visual attention. So there are also job aids that we may think about and conversations with their employers, if that's appropriate, to think about some ways to maximize their attention, and particularly around the visual areas. So those are all some of the initial techniques that I would have, but no particular apps or particular programs that I recommend because many of them are quite good. And many of them have been developed by those with ADHD as well.
Okay, perfect. Thank you. Okay, so we
Uh,
talked about just psychostimulants as a medication, the gold standard medications, others exist. And then the difference for treatment for children and adolescents versus adults. and then the substance using population, if there's any differences between those three.
Now, for the substance using population, this is a very interesting conversation to have as well, because there are certain substances that people use. They don't have a use disorder per se, but they use certain substances that make their ADHD worse, and cannabis is at the top of the list. Now, there are many people who are listening who will probably argue with me on that point. They'll say, no, cannabis actually improves my attention and concentration and so forth. And perhaps in some individuals that is the case. But as a population, cannabis tends to make attention worse. And that's been well documented. So oftentimes I have a conversation with patients to say, we really need to look at your cannabis use and figure out a way to limit that, because I do think that that impacts your attention, and adding medications on top of that doesn't necessarily make sense as a starting technique. So again, can we address the cannabis while we're also looking at some medications? Of course, if there is an underlying use disorder on any substance, addressing that, even reducing use, is going to be helpful to maximize attention and executive functioning. So very important as well. But I want to give a huge caveat to the addiction treatment providers who are listening in today as well. I want you to think for a minute what your addiction treatment programs are like. It could be a day treatment program where there are 8 hours of sessions throughout the day that have a lot of content that has to be learned, or homework that has to be done as well. Schedules that have to be maintained, AA meetings to get to, showing up on time for various parts of the treatment program, and then also a lot of content that we're teaching in educational formats. That is a nightmare for someone with ADHD to try to navigate. And so as we look at our treatment programs,
Let's be
often
honest, Mason, that's a nightmare for any of us.
that's actually, it's true. It's a nightmare for any of us. Yes, I would agree, Darlene. But especially for those with ADHD, I can't tell you how many times I've had people tell me, well, this patient isn't committed enough to treatment, and they just discharge themselves and they're going back to use. Well, let's ask some questions about that. Why did that occur? Why was it this person couldn't make use of the treatment resources that we had? And are there ways that we could think about providing that treatment in a way that is much more friendly to their diagnosis and much more accessible to them as an individual? So again, very important to think through what this is like for that individual and how that actually works against them in terms of learning that information.
You just described drug court, treatment court.
Yeah, that's right.
Treatment court is
Thank you for saying that.
so complicated. It overwhelms me. And people go in and they have to call every day. They have to check in every day. They have to go to do a UDS within a certain time frame. They have to do so many. Man, it is tough. And the consequence is often a jail sanction. Talk about learning, the difficult way to really manage and get your executive functioning online by coercion. So you're right. That's such a salient point that how can we make it a little bit more friendly to people with this condition? I really like that.
What's very interesting, I think I've been around this field long enough to remember that the idea with treatment initially, if we go back to like the 70s and 80s, especially, but even persisting into the 90s and 2000s, there was this idea that people with substance use disorders are living very chaotic lives. And in many cases, they are. They're managing a lot of different issues at one time. But it was thought to be the role of the treatment programs was to impose a structure and order, to teach executive functioning, if you will, to teach showing up on time and what have you. The problem is that sounds great from a theoretical construct, but it doesn't really work in real world practice. And I think that's what many of us see in the treatment field, that we have to be flexible. We have to meet the person where they are and really maximize their chances for success.
Unfortunately, a lot of people had to die for us to figure that out. That's the terrible part.
It is. It's both true and it's terrible as well.
Yeah. So other things when it comes to treating, so this is the controversial part of when do you use stimulants in the substance using population? Because that's where you have some programs where it's just not allowed. When would it be appropriate? What criteria do you use?
Yeah, so I think this also is a really important and very controversial point. And we actually don't have much evidence to guide our decisions around this as well. I will say from my clinical experience, having worked with this population with co-occurring ADHD and substance use disorders for 20 years now, I will say I do have some clinical experience that may be helpful to think about. One of them is to recognize that people, particularly those who are abusing stimulants or have a stimulant use disorder, they will require higher doses of stimulants than someone who does not have a stimulant use disorder. That is well documented in both adolescents and adults. That, by the way, also really kind of can raise your hackles a little bit when you're using higher doses of stimulants in someone who's in recovery from a stimulant use disorder, and you begin to think, is this okay? Like, why are they requiring more medication? Are they being tricky with me? Are they actually requesting more medication, med seeking behaviors, and what have you? And so, first of all, I would say that if you are going to use stimulants in this population, important to recognize you may need higher doses of stimulants to get the same effect. The other piece that I would add before I really jump to stimulants, and many patients will come in and say, "Hey, I'm a month off methamphetamine, alcohol, whatever. I'm ready to get onto my Adderall." Great. Okay, maybe. But let's talk about what are you doing that is not Adderall? What behavioral interventions are you doing? What organizing interventions have you looked into? Do you have an ADHD coach or some other individual is helping you to think about how you organize your life so that we can kind of maximize that executive functioning? Let's try some non-controlled substances first. Let's see if perhaps atomoxetine works or another medication before you leap immediately to a stimulant. But I will say that oftentimes those don't work. And oftentimes individuals are struggling to actually get to their treatment court appointments and what have you, or other things that are part of their treatment or part of their work, trying to get them back into a more functional place in their lives can be difficult. And so I will make the decision to use stimulants sometimes as well. And I would say that it's not always my go to, but I do use them enough that I think I've got some experience with how this kind of works in the population. And typically, I always go back to how confident am I of that diagnosis? Do I have symptoms going back to age 7, 8, 9 years old? Or did I make this diagnosis, 3 months into recovery in a 25-year-old? And typically, if I'm going to use stimulants, especially in someone who's that early in recovery, I want to make sure that I understand the diagnosis was made either as a child, as an adolescent, something I can point to really have a confidence in that diagnosis. If I have confidence in the diagnosis and I put certain safeguards in place with the stimulant medications, they can be used quite effectively and quite safely. A couple of things to keep in mind: always use longer acting preparations where you can. I usually will start with something like methylphenidate, which probably is not quite as psychoactive and quite as people don't feel it quite as much. And so that's oftentimes a good place to start as well, and not leap immediately to a dextroamphetamine or even an oral methamphetamine, which is available if you wanted to use that as well. Those are not first line agents, in my opinion, for this population for sure. So, again, how confident am I in the diagnosis? And then what safeguards can I put in place to make sure the patient doesn't divert the medications? Now, a word of caution: I will say there have been several very large epidemiological studies done in countries outside the US for their very good registry records, and diversion of stimulants is a real thing, whether you have ADHD or not. And there is evidence that diversion occurs at 4 or 6 times the rate of non controlled substances. Not as high as opioids, but certainly this is an issue we need to be aware of and be very cognizant of, using the lowest dose that's effective, very small, manageable quantities to begin with, and very tight controls over refills.
And we did an episode, Mason, reviewing the ASAM treatment guideline for stimulant use disorders. And it's really lovely to be able to review those guidelines, which are evidence based. And obviously, a lot of time is taken to put those recommendations down on paper to help us as providers to make these decisions of what to try first, what indications really exist for which conditions, whether it's cocaine type, methamphetamine type, whether you want to cross over, and then who should be prescribing stimulants to people with stimulant use disorder. And this is not to disrespect family medicine or internal medicine, but it really should be addiction psychiatry or addiction medicine treating people with active substance use disorder or a history of substance use disorder with a stimulant, according to that guideline anyway.
That's right. And I think I would also add that when we're treating ADHD and with a co-occurring substance use disorder, I do differentiate those who have a substance use disorder with a stimulant use disorder versus other substance use disorders. So someone with ADHD who has an alcohol use disorder that is beginning to get into recovery or reducing their use, I'm probably going to have a lower bar to use stimulants than in someone who's in recovery from a stimulant use disorder. Again, I have used stimulants in those cases and do use stimulants, but I do typically want to make sure that I'm very comfortable that they're going to be able to manage that in a way that's productive. also acknowledging that treating their ADHD will probably result in reduced use of the substance as well and improve functional outcomes. But to your point around who should be managing these conditions, I think I fully agree with the ASAM criteria. It should be specialists in addiction medicine or psychiatrists. Frankly, even psychiatrists who are specialists in addictions is even better. Recognizing that not every community, not every person has access to those individuals, I do think that consultation is important. But if I was someone who wasn't trained in addictions and didn't really have active consultation with someone who was, I probably would not treat that patient with stimulants. I might treat them with other medications, but using stimulants in this population, you really want that specialty level of expertise and guidance and consultation. I also, by the way, will frequently require my patients to be in some degree of psychosocial treatment as well. So I really want them to learn skills to deal with any potential issues that may arise with use of these medications and not just prescribe the medication and then wish them well, but really to say, we're going to try this for the ADHD management. I want you to also be in treatment to learn some skills to manage your substance use disorder as well.
That's really helpful. I I have a question about co-occurring psychiatric conditions with ADHD. How often do you see anxiety disorder and ADHD together, or a mood, depressive disorder and ADHD? And are there any tips you can give us on how to, when you come to that decision of, okay, it's not either or, it's actually probably both, and how tricky it is to treat something like anxiety and ADHD, and of course, where one can cause the other. Like you mentioned before, ADHD can be anxiety provoking because you're always, behind the game and disorganized and kind of failing in life responsibilities.
It's a very challenging issue to treat and kind of to think about because we see a lot of co-occurrence with ADHD and other psychiatric disorders as well. And then if you add substance use disorders on top of that, you've really got a very complicated situation on your hands. Oftentimes, I look at what the patient is leading out with. What are they coming into treatment for? Right. So if they're coming into treatment for a substance use disorder, let's start there. If they're coming in with a chief complaint of depression, let's start there and really see where we can get in treating what the patient identifies as the biggest issue for them. Now, in the case that I might have records or I might have some information going back to childhood, and I have again that confidence in the diagnosis of ADHD, we might go ahead and do both together. We might treat both conditions simultaneously or let the patient choose which they feel like is the more salient at the moment. I will say that we run into real problems in managing ADHD and bipolar disorder and ADHD and psychotic disorders. Now, fortunately, ADHD and psychotic disorder is not a very common combination. ADHD and bipolar with substance use disorders is a fairly common combination. And in those particular cases, because of the risk of triggering a manic episode with stimulant medications, I will make sure that bipolar disorder is really well controlled and then gradually introduce low dose stimulant medications if I use them at all. So I would say, frankly, for your listeners, it's really important to recognize while we worry about ADHD and substance use disorders, and we want to think about that, we really need to think about treating bipolar and ADHD together. And if you have someone with psychosis and ADHD, you can also make the psychosis worse with treatment for ADHD as well. So again, how you manage all of that, that's really the territory of psychiatrists. And frankly, if I have somebody with that many comorbidities, I'm probably consulting with an ADHD specialist myself to understand what to do because it gets very complicated very fast.
Could you answer a specific question regarding the use of bupropion and psychotic disorders? I know this is a bit of a tangent, but I think you may find different answers with different psychiatrists. But if you're using a non-stimulant like bupropion for a patient for their ADHD and they have a risk for psychosis, like they've had it in the past with a bipolar, a manic episode, or a substance abuse episode, do you avoid it at all costs, or are you careful with it? What's your take on the use of that medication?
So the way that I think about this myself, and again, there is some evidence to guide us in this respect, but not a huge amount. But I really think about managing that primary condition that's going to land someone in the hospital or have a suicide attempt or possibly a completed suicide. So the psychotic conditions and the manic conditions and the depressive episodes when they're severe, those are the ones I want to get under control first. And so, especially with psychosis, we'll medicate that first. Bipolar, fortunately, a lot of the medications are the same for those two conditions. So we can actually get that under control and see what we're left with and see what the patient still wants to be treated for. But you can use Wellbutrin, bupropion very effectively in these cases, and you can use stimulants as well. I will say in most patients with bipolar, I would start with bupropion probably first, but it's very safe to use in most cases.
Thank you.
Just thinking in some of our special populations, how about some of our older patients where maybe are 65 and older? Because we frequently are getting more and more of this population that are coming in and for this is their first time in recovery, but still seem to be quite symptomatic. And they also seem to also have the most side effects with the stimulants. So is this where you want to avoid them? Do you tend to go with sometimes the non-stimulants first? What's your general approach?
Yeah, I think older patients actually present a really interesting problem in many respects because we have a couple of issues that are coming together at one time. So first of all, we know that as you age, certainly as you get into 70s and 80s and beyond, your brain becomes less flexible and less plastic. So the plasticity and the neural networks and everything that you're used to having in your 40s or 30s or 50s, what have you, are not working quite as well. And so oftentimes we'll see the ADHD symptoms becoming more prominent or the executive functioning becoming less. And in general, executive functioning issues do happen as people age and they become less able to actually execute those functions. And that's pretty well documented, I think pretty well understood. So we want to make sure when we have patients coming in, especially that are getting into recovery for the first time or addressing their alcohol or other substance use, to again go back to the diagnosis, understand what's happening in the brain of the person in front of us. Can we tease out minimal cognitive impairment or dementia from ADHD, from effects of the substance, from anxiety and depression? All of that will take a bit of time. And so that's okay. I think it's important to take the time to understand the diagnosis, and then you can actually think about what the treatment is. Now, to your point around stimulus being, really less tolerated by older individuals, that actually is very true. Although we can use lower doses of stimulus sometimes very, very effectively, particularly methylphenidate, I think is one that a lot of us would use in this situation. But oftentimes they do respond better to the non-stimulant medications than their younger counterparts. And so oftentimes an atomoxetine will work well in a 75-year-old when it won't work well in a 25-year-old for whatever reason. At least that's been my clinical experience.
That's a great question. So we've discussed older adults and patients with substance use disorder, and then adults in general, and children and adolescents. Have we missed anything that, Mason, that we really need to know, that our listeners need to know about ADHD?
Yeah, I mean, I think a couple of things to know about the treatment for ADHD in general. The treatments really work well, they work fast. There's a strong family history of ADHD usually. So in this particular situation, I think about ADHD psychosis to a degree, and then bipolar disorder. Family history is extremely important in the diagnosis. And oftentimes, the confidence in an ADHD diagnosis will go up for me significantly when I hear that 3 first-degree relatives have it as well. So again, important to ask that question. We don't always do that, but I think that's an important question for this particular diagnosis. So that's one piece of information that I will put out there. I also think that the medications for ADHD work quickly and they work well, but it's important to have some way to measure that it's working well. And unfortunately, we don't have great scales to do that. So if there's someone in that person's life that actually is around and maybe around them every day, a spouse or even a kid, I've asked in some situations, or others that are around this person, even a boss in a couple of situations over the years, ask them to have an appraisal of this person's attention and performance, cognitive performance from point A before they start the stimulant medication to point B when we have a reassessment. And that is really useful information. And I found over the years that that helps me to really sort out the diagnosis, the response, the dosing, even. I mean, that's a really pretty crucial part of it. So that's another piece that I would really throw out there.
Mm-hmm.
The other thing that's important to keep in mind, and this is, I think, for your listeners, whether they're providers or people that have struggled with ADHD, this is a protected diagnosis under the Americans with Disabilities Act. And so typically that requires schools and employers to provide reasonable accommodations. And I have had situations where I've had patients who are about to fail out of college or about to leave college. And then we actually worked with the Office of Disability at that school, got accommodations, and the person made A's and B's and was able to graduate. So really important to keep in mind that there are legal protections when you have this diagnosis that can be used to actually get accommodations that can be helpful and useful in the management of ADHD. So those are a couple of just a handful of clinical tidbits to think about.
That's great. That's very helpful. Thank you.
In summary, like Mason, really, I think the key pearl is taking your time for the diagnosis. I think is so important with ADHD. That's one lesson that I've really taken home, that, and then careful and close monitoring. And because and an understanding in the US, it is a Schedule 2, and that is for a reason. It does have that risk of diversion. So making sure that we have good compliance monitoring set up around that. And when we are prescribing, particularly for those with stimulant use disorder, that, or any substance use disorder, that we are careful monitoring and then revisiting our diagnosis. I mean, I think that should go with all probably mental health diagnosis. I think sometimes we get pigeonholed, and sometimes people come to us diagnosis and we forget that, hey, if your presentation looks different, we should step back and take a look. Am I summarizing all? Any other points? What else have I missed? Did I pay enough attention, or do I need to come see you? That's the question.
You paid great attention, Darlene. I think you got all of the salient points out of a pretty information-dense conversation, that's for sure. Just a couple other things I would add that occurred to me. So one, I think the role of neuropsychological testing with ADHD, particularly with kids, but also with adults, keep in mind that those testing results only really tell you what the concentrational abilities of the patient are. So it doesn't diagnose ADHD. ADHD is a diagnosis a clinician makes via an interview with objective data from testing and screening and so forth. So really consider that testing data to be part of the picture, but not the whole picture. That's primarily focused to the psychiatrists who are listening to this, because I think over the years, I certainly have over-relied on those testing results. It's another piece of data that helps us to make the clinical diagnosis. The other thing, Paula, to your question earlier around like the consultation piece and who should be treating ADHD with substance use disorders, if you're going to invest time in a consultation or sending a patient 4 or 5 hours away for a visit, what have you, do it to make the diagnosis. Have a friend that you can call that can help you make the diagnosis, or that can see your patients to really confirm that diagnosis. The treatment and management of ADHD, medically speaking, is pretty straightforward. In fact, it's one of the more straightforward conditions to manage that we deal with. But that diagnosis is really so crucial that you want to have some people you can consult with and really invest time up front in getting that diagnosis correct, unless it was made as a kid, and then you can have a lot of confidence in that.
That's an excellent recommendation. Thank you.
Great. Thank you so much. That was such a fantastic episode.
Great,
I'm going to employ an ADHD coach for some of my family members and start color coding our calendar.
That's right.
That's excellent.
Those are my take-home points for me personally.
It's great.
Thank you, Mason. Thank you once again. That was very helpful.
Until next time, hey, check us out at theaddictionfiles.com or email us at theaddictionfiles@gmail.com. Thank you so much to Ricky Valades for use of his song Awake. Check him out at rickyvalades.com.
Podcasts are for entertainment and education purposes only. Hosts and guests are not responsible for any harm caused by information obtained from this source. As each person is unique, you're advised to seek the advice of your own healthcare professional to treat any medical conditions you may be having. Opinions expressed on this show are those of the Addiction Files and not of our respective employers.